Beautiful. Thank you so much, everyone, for joining us for this concurrent session. We are here doing a Q&A with Dr. Mark Horowitz and Professor Julian Trollor to understand more about their presentations today on effective prescribing and deprescribing. We know that when we did the webinar with Dr. Horowitz back in November, we were inundated with questions. He couldn't escape from our live stream because he had so many questions, which shows how deeply people connected with this topic, how much people wanted to hear more. I am going to use this time to give a plug for the Maudsley Deprescribing Guidelines. Please get your hands on a copy of this. This is such a fabulous resource for both clinicians and non-clinicians, for people who are interested in this work, who are interested in effective prescribing and deprescribing. Thank you so much, Mark and Julian, for a wonderful session this morning. Your content has so much depth and breadth in terms of the issues that you are raising. It certainly highlighted the challenges that the people in this room are grappling with every day. We will take questions from the audience. Michelle is in the corner. She'll be facilitating the roving mic. What we would like to do is just start with a question for both of you. We know that there are lots of myths and mythologies about the work that you do about effective prescribing and deprescribing. If I could start with you, Mark, and then you, Julian, what's a myth that you would like to use this session today to bust in terms of prescribing and deprescribing?
So many myths. Is this working? I think one of the main things is that when people stop medications, that any issues that arise must be evidence that they need the medication and their underlying condition is coming back. I think that's, very prevalent. I think the idea that, these drugs fix underlying chemical imbalance, is a justification to use these drugs lifelong, and I think that's needs to be unpicked, and drugs to be seen as mostly acting on suppressing or constricting symptoms. And so I'm repeating myself, but I can't do it enough, that, the smallest tablet is a small dose, so you can just stop it. Stopping over a few weeks is stopping gradually. That symptoms, when you stop, go away in a few days or weeks rather than months and years. And patient being told, patient after patient being told, this cannot be because of coming off your drug. Inevitably, it is because of coming off your drug, and it can be, muscle cramps and headaches and dizziness and panic attacks. So I think we have underestimated, how profound the effect on people's nervous systems are from these drugs. And maybe one thing that, I think that there is not much research on the long-term effects of these drugs. I think there are lots of circumstances where they can worsen underlying conditions, where they can contribute to functional impairment, they can contribute to emotional ups and downs. Maybe to really one last thing is, I think the way that drugs work. I mentioned this sort of drug-centered model. I think that there is, it sounds somehow forbidden to say, but there is a lot more in common between psychiatric drugs and street drugs than people like to admit. Benzodiazepines are essentially alcohol in tablet form. Antipsychotics, before they were framed in that way, were called matrix tranquilizers. If anyone's tried a small dose, you cannot think straight. I've had, a quarter of a 25 milligram of quetiapine and could barely, make a sentence for 36 hours. Antidepressants, have very similar biochemical effects to ecstasy or MDMA. They're not as potent. And I think when you think about drugs like in that sense, you can understand why they would make people feel better, a bit euphoric or a bit numbed in the short term, and why they can have very different effects in the long term, cause cognitive impairments, cause metabolic disturbances, cause all these things, because I think fundamentally they are disrupting the normal biology of the body. That doesn't mean they shouldn't be used. I think there's roles for them, but I think that unless you frame them in that way and understand that that's a possibility, you can't use them safely. So sorry, that was a long answer to a short question.
That's a great answer. I have two myths that I'd like to share. One is that we know everything we need to know about medications. I think this is best illustrated by an example. When I was much, much younger, and we didn't know that drugs like sodium valproate could increase suicidality, I was prescribing in the context of someone who had epilepsy, who on initiation of valproate had substantial suicidal ideation that had been really in the background for that person and maintained and addressed through other issues. But on starting valproate, had this really dramatic increase in suicidal thinking and heightened risk. And it took me a long time before I accepted what the person was saying. I did, which was great, and we stopped it. And then we experimented because this wasn't known. So we said, well, okay, let's think about this. Let's make sure you're safe. You do need a medication for seizure control. Let's try again. And exactly the same thing happened. So, we had a little experiment, if you like, albeit one that was where the risk was managed. And later, many years later, it emerged that valproate was associated with suicidal ideation for some people. So that even with older drugs, we may not know everything we need to know. And so we need to listen to the person. And I think, some of the personal experiences that are shared today have really helped us understand that. My second myth, I think, is that, it's not a myth. If you're a researcher, you know that correlation doesn't equal causation. And so when we're thinking about the impacts of prescribing or deprescribing and thinking of linking changes in the person, either changes in their mental health status or their behavioural status to what we're doing, we must be really, really careful. An example, I could start, say, low-dose quetiapine to help control a behaviour in a person. I wouldn't do that. But say, for example, I did, and the person's behavioural behaviours of concern reduced within a short time. If I hadn't understood that that person was living in a situation where they're unhappy in the shared accommodation, where they were being bullied by a person, and that person had recently left so that the behaviour is no longer an issue, I might have concluded that that person needed ongoing treatment with the medication and that it was successful. But I didn't know all of the information. It was simply a correlation. And in that circumstance, it can lead to us continuing a drug. Likewise, if I'm withdrawing a medication and I get data from the behaviour support team that indicates a sudden escalation in the person's behavioural pattern, and I don't know all of the facts and what's going on for that person, I might conclude that my reduction in the medication that we initiated is the cause of the behavioural escalation. But there could be many explanations of that behavioural exacerbation. So I need to be very, very careful. I need to perhaps wait and be more considered in further decision-making in regard to that medication. So I think, the idea that correlation isn't causation and we need to factor that into our assessment of what we're doing and decision-making with medication and have all of the information available.
All right, we've got a question from the back.
Hi, me again. I've got a couple of really quick questions. One is, Professor, you mentioned in your last speech that a lot of what's prescribed in disability are the old medications. I'm really that fascinated and kind of blew me away. I want to know why, how. And my second question is for both of you. We now know there are so many links to diet, to gut health, to inflammation, to all of those things. How can we get clinicians to look first at root cause and experience and not, for example, prescribe antidepressants for grief?
Yeah. Should I go first, Mark? So I think in regard to the old style medications, there's quite a lot of anxiety, clinician anxiety around assessment and management of people for whom you've been not equipped as a medical student or as a health clinician. So when you come into that setting and someone's been on a medication, it may be for many, many years in an older style of medication, for example, an older style antipsychotic, and things are going okay, you're inherently reluctant because you don't feel you have, you're fully competent, that you don't feel you have enough specialised knowledge to do things differently. And so there's a reluctance to change and go with something new when something new might be better and expose the person to less risk. So I think that's a key. We are struggling, and the second part of your question is we're struggling to deal with the health needs of people with intellectual and developmental disability, and what we're dealing with is the tip of the iceberg, and we're not getting to the preventive health needs. When we saw what general practitioners were doing in the Beach data set, we could see that the occasions of service were driven by mental health needs and by paperwork demands that person had associated with them. And all of the preventive healthcare items, health checks, checks of other aspects of preventive health and the prescribing associated were not got to because of the clutter around this top tier administrative burden associated with the person. So we need a different model of service to enable us to get to all of those preventive healthcare needs, including diet and lifestyle factors, because we know as a population, people with intellectual disability have incredibly poor diets, often not supported in the right way to eat well and to exercise well, have a lot of different barriers in participating in healthy lifestyles. Unless we get there, we won't prevent that cascade to early death, because most of those deaths are cardiometabolic deaths, and that's a real concern.
AI has a place in that, in terms of helping diagnose root cause and reducing administrative burden?
I think so. So too is a different model of care where a lot of the administrative work is done by others, and the people with the skills to help address those preventive healthcare needs are able to use those skills. GPs are incredible. If you've got a good one, and most of them are fantastic, that's their bread and butter, is helping us all to live healthier, active lives. The fact that you can't get there for a person with a high level of complexity means that we've got a problem with our model of care and our remuneration for those types of things, and the supports that are provided around that way of practicing in a more complex, for a person with more complex needs.
Maybe I'll take up the section of the question about pathologizing normal distress as mental health problems leading to long-term medication. I think that's a huge problem. I think we can see this huge expansion of diagnosis. There's a study that shows that if you follow people in New Zealand from birth until the age of 45, 86% of people meet criteria for a mental health problem. Most of that is anxiety and depression. So about 70% of people by the age of 45 meet criteria for major depressive disorder or generalized anxiety disorder. In other words, it's normal to be depressed or anxious. The studies, people ask me, if it's not serotonin that causes depression, then what is it? I think everybody's grandmother knows the answer to that question, that it's things going wrong in life. There are lots and lots of studies now showing the number of stressful life events you have in a given year predict very closely your risk of depression in the next couple of months. If you get divorced, lose your job, move city, chances of being depressed are very high. None of those things happen. It's very low. People's personalities play a role in that. And I think that we as a society have been taught that these things are, illnesses and not normal responses to life. I know the cultural history in England better than I do in Australia. There was a campaign called Defeat Depression that ran for 10 or 15 years, presented by the College of General Practice and psychiatrists, presented to the public, and its message was, feeling hopeless and low and depressed is a mental illness, and go see your doctor. They now have new solutions for this problem. And the public was very resistant to this for two reasons. Number one, they thought depression, being low and hopeless, is not an illness. It's what happens when you get divorced and lose your job. And number two, that any drugs given for these conditions will be dependent or addiction forming. And so the campaign focused on pushing over those two pieces of resistance, which is where an illness like any other illness line came from. And they repeated again and again, these drugs will not be hard to stop. They're not addictive. And it was successful. And the rates of antidepressant prescribing in England over that 15 years went up from 3% of the population to 15% of the population. And of course, the campaign was funded by drug companies, although it was presented by the colleges. And so we have now a society that's been transformed into believing that mental illness is everywhere, and that every abnormal, every unpleasant feeling is a mental illness. Which is, I think, although 1 in 6 adults in Australia are on an antidepressant, 1 in 2 have been offered an antidepressant at some point in their lives. Because if you go to a GP and you burst into tears or you're upset, GPs under time pressure, wanting to do something, wanting to help, pull the simplest thing available. And so I think depathologizing distress is a very important aspect. It makes me think a little bit of the analogous campaign to depathologise coughs and colds, that, you know, if you have a cough and a cold, you don't need an antibiotic because mostly it's viral. I think there's something similar needs to happen to push back about, you know, every unwanted feeling, you know, or behaviour being something that needs a diagnosis and medication, because prescribing rates are doubling every 10 years in this country. So, you know, very soon most people will be on some kind of medication for mental health. So I think something needs to be done to, you know, normalise, you know, being down. The other fact that's also worth knowing is for severely depressed people who are admitted to hospital, so a pretty severe group of people, those that are given no somatic intervention, in other words, no drugs of any sort, the recovery rate is 85%. You know, the internal documents from drug companies about antidepressants was, I don't think we have a market because the recovery rates from this condition without treatment is too good. So I think that needs to be borne in mind, that, you know, tincture of time, amongst other things.
I've got two things. One quick one. You mentioned akathisia and withdrawals from SSRIs or antidepressants. Is it the same benzodiazepines?
Yes. So,
yeah,
you know, there is some, I don't know, it's a common final pathway, but coming off benzos particularly, I would say,
yeah,
it's likely to cause akathisia.
The other question, it's sort of a question, sort of just want your comments on it. We're all sitting here in our different roles and we're talking about depathologizing, but then we're interchanging mental health with behavioural health. Mental health is a euphemism for mental hygiene, which is related to mental illness. So we're really just talking about mental illness when we talk about mental health. And now we're moving towards positive behavioural support, which is about behaviours of concern, which in practical reality, in my clinical experience, is we need the person who's the subject of care to stop doing what they're doing. Are we really going to cease or reduce prescribing behaviours when we've just created a new language to continue to ask someone not to express legitimately what is their social construct and their social determinants? And I guess to add on to that, in the UK, there's been stuff going through government around deprescribing and prescribing. And do we need a position that comes out of the government and the Royal College of Psychiatry and the Australian College of Mental Health Nurses and the Positive Behaviour Team organisations before we start asking people to try and practice in a different way that is wholly impossible? And from my clinical experience, if I practice outside the hegemony of psychiatry, they make a ARPRA notification. So is there a case to have one position at the highest level, and then we can think about whether we can deprescribe, or are we just blowing in the face of the wind a little bit at the moment?
I mean, I'll take one part of that. I mean, I take your point. You know, I do, you know, feel that I'm bringing a sort of a little fork to a huge thunderstorm, you know, and the idea of coming off the drugs slowly is a very small part of the elephant. You know, you're right. The broader context is, sort of take your point, I must have used the word mental health, that, you know, all of this is, you know, I think all of this is framing, as you say, social determinants of health, you know, being a very big driver of these things as individual, you know, mental illnesses, sometimes down to individual chemicals. You know, I do think there needs to be a broader conversation about, you know, what is causing these things. And you know, in some ways, people say that's a utopic way to talk about things. You know, if you make a fair society, there won't be any mental health problems. But I think it's just rational. You know, if you're trying to medicate everybody because of, you know, inequality, poverty, poor jobs, environmental degradation, you know, you really are not. It's not a very cost-effective way to do things. Not very effective. So I do think there needs to be a broader conversation. You know, at a political level, it's not about. It's very hard as an individual clinician, I think you're saying, to kind of go against the grain. You know, it does need to be a part of a broader conversation. There's a group of psychiatrists that want to put forward something called the Not Broken Brain Project, which is to get this idea out there a bit, you know, the public sort of messaging I'm talking about. This is about people responding to social circumstances in lots of understandable ways, and the way to help them is to deal with social circumstances, not to give everyone a specific medication. That is a very, I think, you know, seems like a very radical idea in the current consensus, where mental health messaging, you know, anti-stigma campaigns, which on the one hand are very good to talk about things, but also sort of reify mental illness and make people hyper aware of it. So I agree with you, there needs to be a broader shift. Not sure how to achieve that. Julian, too.
I love Mark's analogy of a fork in a thunderstorm. I think it's a lightning conductor, you know. I just have this image. as a kid who was nearly struck by lightning, it really set me off. Look, this ambiguity in behavioural presentation, mental illness, was explored a lot by in the Royal Commission, and I think as a clinician, I see that a manifestation of all mental illness is in changes in behaviour. So I guess I'm not so distressed by the lack of clarity on the issue. I see that for some people, there is a presentation with what I think is a definable or diagnosable mental illness. And I having done a lot of research in understanding the barriers and enablers to access to mental health treatments for people with intellectual disability, I would hate to see a situation where we're saying we must reconceptualise everything as behavioural rather than for some who may have a severe underlying mental illness which needs access to appropriate treatment. So I'd be really concerned that the pendulum should swing back too far. I do think this whole area of practice could lead the way in the way that we're thinking quite clearly about how to prescribe responsibly in a very narrow framework. And to me, that's not something that is occurring in our general society. So I think among people who have perhaps the greatest risk of mental illness, in whom they also have the greatest scrutiny around prescribing practices, I think what we do in this space is really helpful to set the tone and approach for the general community and reset in the way that Mark was talking about. But I do feel anxious that we don't overcorrect. There are people with very severe and profound mental illnesses who need access to treatments. Now, for the majority, the treatment should be psychologically based treatments and other treatments. For some, they'll need a combination of pharmacotherapy. For some, they'll be more heavily reliant on pharmacotherapy because of the nature of their illness. I think we have to be very cautious. That's my view.
Thank you. Can you provide some general comments about use and prescribing of psychotropic medication in regards to older people, and in particular people living with dementia, and also in residential aged care? And any thoughts on that?
Sorry, I can give some general thoughts, but it's not my area of practice. I mean, I think that older people are more prone to side effects from drugs because their livers and kidneys are not as effective as at metabolizing the drugs, and so you've got to be more vigilant for adverse effects and use lower doses and be more cautious. Behavioral issues in dementia is not my area, but I know that lots of non-pharmacological strategies can be more effective. People wander and not trying to control behavior as tightly as you can, and using medication as a last resort at low dose, for short periods of time makes the most sense because, in my area, antidepressants, antipsychotics, the risk of strokes, falling down, fractures, increased risk of cognitive impairment. Big paper just came out showing people with dementia that use antidepressants have a higher rate of cognitive impairment over time than people that don't use it. So I think everything I've said in my lecture is more so true for older people. My general point.
I'd agree entirely. I think it's a very high risk group, and we have to be very, very cautious. And the risk of harm is very high. I'm excited by the developments in the psychiatry of old age and in psychogeriatric practice in general to provide sophisticated behaviour support for those in residential aged care. And I think that's a really useful model. For me, the deprescribing trials that were run by Henry Brodati have been really helpful in informing my thinking about deprescribing in the context of intellectual and developmental disability. And I think seeing the sophistication of behaviour support models in that context, I think that to me is the place to go. But inevitably we find those services and supports, under-resourced. In the same way, I think we see these ways of working under-resourced in our intellectual and developmental disability settings. one of the keys for me is not just that we fund adequate assessments, that we fund the implementation of a really sophisticated behaviour support plan. I often see great plans, but the implementation of them and the interdisciplinary aspects of that are just missing.
Yeah, hi. Yeah, thank you both for your talk today. Does the law of mass action apply to most medications, especially ones that affect neuron activity?
Yes, yes. Sorry to introduce that jargon, but yes, the idea that small doses have much larger effects than people think, is true for all psychiatric drugs. Because of that sort of that when there's not much drug in the system, all the receptors are open, and so I think that the take home from that is you often need to go down to very small doses before stopping, so you're not falling down that steep cliff. I think most doctors and patients, when they see those graphs, are surprised by them because everyone's been taught this dose, the smallest tablet, is a very small dose, because they find it quite confronting to see that it's not quite the case. It's definitely reflected in patients' experience. And I think, when people hear that 1 milligram of mirtazapine or citalopram can have a profound effect, most doctors, laugh a bit at that. And I might have as well if I hadn't been on the receiving end of it. So I think that if people can get their heads around that, it can lead to a lot of a safer practice. People understand the effect of those small doses.
Just also interested in exploring the inter-individual differences. I think for some drugs it's quite profound. So some stimulant medications, for example, methylphenidate would be a good example. After a single dose of methylphenidate, the blood level in the system can be up to a 10-fold difference from one person to another. So, there are some drugs where inter-individual difference comes into play around both understanding the experience of bad effects on initiation or no effect. And so I think we need to also factor that in. Mark might have other comments about how that bears out with most commonly prescribed drugs, but to me that's a huge factor.
No, I agree. There are big differences between individuals. I think that's why I talked about adjusting the rate of reduction to the individual, because although there are some papers out there and risk factors, I think it is very hard to pick it. And that's why although I've spent endless months writing up dose reduction regimes, ultimately it's how the patient responds that should be the primary issue, and that should be the be all and end all.
Yeah, and listening very carefully to what someone is saying as they report what's happening, I think is critical. We tend to think in populations, think, oh well, this group might be more vulnerable as a whole, so we'll start slowly. But actually for someone, it might be starting incredibly slowly, and it might almost sound ridiculous, but that may be what's required. And likewise, stopping. We need to be very careful.
Hi, my name's Sophia Chekovic. I'm a registered nurse. I'd like to thank you both for your careers and your dedication and how much you've taught me individually. I'm just interested, Dr. Mark, about how you were talking about the notion of the receptor and injury occurring when there is a flood of serotonin. And so I know that we've got to taper down very slowly, but is there any benefit in starting low and going slow to not flood the neurotransmitter to cause that damage, or does it not matter? It gets to that level and the damage is done.
Yeah, I mean, so I think on the simple question, I think Professor Trollor would agree with me. Yes, it always makes sense to use the lowest available dose. And I think, you see based on the graphs that 1/10 of the dose of the minimum generally recommended dose has half the effect. People again laugh and think it's homeopathic, but every good clinician should be balancing the harms of a drug versus the benefits. If that ends up being 1/10 of the dose, fantastic. So I'm all for that. It's a bit tricky because tablets only come in certain sizes. You have to use liquids and things but if you can quarter a tablet, that's better than using a whole tablet in my view. On the topic of injury, which is a little bit of a, hot button issue, because, I guess the reason why I use that terminology, and another doctor outside said that was useful. Look, the people that I run a clinic in London, and we see two types of patients. We see people that want to come off their drugs, and we sort of take them through these slow reductions. And we see people that have come off their drugs already and are in a very bad state. Some of the patients, you kind of got the flavour from the videos. And, the textbooks say if you have trouble coming off a drug, you're in withdrawal, we'll give the drug back, problem solved. And it's not problem solved with these people. So I don't know what's going on, because withdrawal means, you stop heroin, you're in terrible trouble, you go back on it, everything's solved. That does tend to happen if you go away for a week on holiday, forget your drugs, get brain zaps, take the drug, it does seem to go away 99% of the time. People that I've seen, been months off the drug, they've either been reluctant to go back on because it's caused them so much trouble, or other reasons. And often I will try reinstatement at a small dose to try things out. And some people get a bit better on the drug, and sometimes I'll go up to a full dose and they'll be okay. Some people, it has no effect on them when they go back on the drug. And some people, for reasons I don't understand, their symptoms get worse. They call it a paradoxical response. I don't understand the biology because no one's looked at it. There's no studies, there's no imaging, so it's a completely ignored area. But when going back on the drug doesn't improve things or makes it worse, it makes me think something has changed in their brain that's not responding now to the drug being given back. I don't know what that is, but the word injury makes sense to me, because light hurts their eyes, they can't concentrate, they're getting panic attacks. They were often put on the drug like everybody else because of work stress and divorce. They didn't have any of these symptoms before, and now they can, now they can't concentrate, they can't look at bright light. It looks to me as severe, I said multiple sclerosis or long COVID. People say, well, how can you prove it's an injury? Where's the imaging? It doesn't exist. But these people are so impaired, and in such typical ways. I've seen dozens of patients like this, all with very similar symptoms. Brain zaps that last for months. I've got a friend of mine who's the head of the radiology department in Sydney, who came off antidepressants, and 10 years later, he has brain zaps still. Something has happened in his brain, that has been caused by the drug. People talk about a neurotoxic insult. Does these rapid changes lead to something that is different from just withdrawal? People talk about a withdrawal injury. I don't know. What I do see is people that come off the drugs more slowly tend to avoid the worst aspects of this. So again, I don't know the biology. I very cautiously use this term injury because it makes people demand proof. But I do see impairments that are very worrying to me in lots of people that are very stereotypical. And so I think it merits research to some degree. There's this debate: are antidepressants effective or not? I think that's a secondary concern. My concern is, are these drugs leading to long-term neurological effects in people that can't be reversed? That to me is the primary question. People say it makes me very negative, but I would rather, safety to me is much more important than effectiveness when it comes to drugs. And so that's my position.
Now, both Mark and Julian, you've talked about GPs and working with GPs. We are so fortunate in this highly credentialed room. There are more degrees than a thermometer in this room. I'm so impressed. We have Dr. Margaret Kirku here, who is able to comment on the GP experience, having a depth of knowledge and decades of work with people with intellectual disabilities. I'll hand over to Margaret Kirku.
Thank you. I am a GP, but I'm not a traditional one because of circumstances which I will describe. My first daughter, Catherine, developed severe epilepsy at the age of 11 months, and it was status, so it was quite a difficult one to control. She later was recognised as having autism, and 5 years ago she developed catatonia. Working with my daughter's neurologist, etc., I had to master deprescribing and prescribing, because from the beginning, Catherine was tried on all except 1 or 2 anticonvulsants and never actually managed the standard recommended dose. In fact, it was much, much less than that. And it took a while for everyone to realise what was happening to Catherine. It was treated as a behaviour problem. And the subtherapeutic doses were very, very subtherapeutic. In fact, when her blood levels were done, the report came back, subtherapeutic level, increase her dose. Of course, we weren't going to do that. 2 years ago, Catherine was admitted to hospital with unexplained low sodium, and we still don't know why that happened, but still. When she was admitted, and this was when she had her catatonia, the neurologist misdiagnosed her catatonia as a recurrence of epilepsy, even though there was a psych registrar and also her psychiatrist who said, no, that's catatonia. The neurologist, in spite of our concerns, because Catherine had had trouble with Keppra in a small dose when she was younger, she was put on the recommended dose of Keppra, and even more upsetting was she increased her lorazepam back from 18 milligrams a day up to 26 milligrams a day when we spent something like 3 years getting her to that stage. Fortunately, she had a peg in because she couldn't open her mouth, she couldn't talk, she couldn't void, she couldn't move, she couldn't weight bear, and she just sat like a statue for 3 weeks until they finally decided just to discharge her. And of course, as soon as she got home, the first thing we did was start to reduce her Keppra, but very, very, very slowly. And we used compounding a lot as we were getting her medications down. 2 years ago, Catherine had an NDIS behaviour support plan put in place because of behaviour problems. Recently, the behaviour support therapist said, dropping her lorazepam, her behaviour's gone. Surprise, surprise. And now, after 3 or 4 years, we're actually down to 8 milligrams of lorazepam. And we're seeing the old Catherine coming back. Also her cheeky sense of humour, which isn't always appreciated by staff, etc. But compounding was an excellent way to go because then, for example, at the moment, Catherine was on a 2.5 milligram of lorazepam, and we actually dropped it by substituting to 1 milligrams. So that was a drop by 0.5. But sometimes the dose, like when we were getting off the Keppra, we had to go to compounding because you've got one big tablet. Well, you just can't cut it in halves, etc. So I can highly recommend compounding. Looking at my work side of things, I worked at the Centre for Disability Health, which is the precursor of the current disability service here. And I had a lot of referrals. I was a GP and saw all the patients first, whatever age. And the paediatricians were referring children on the spectrum with behaviour problems. And when they came, it was quite obvious that the doses of their medications they were on were far too high. And so I worked with the parents and also the psychiatrists who we have to have there, which was really good. And we just slowly deprescribed. Some had to come off it totally. Some we got to a level where it was actually helping and they were coping with that. But it was a long, slow process. And it was a matter of really making parents understand that if you try to push it, you lose out. For example, when Catherine had still fairly catatonic, but seemed to have settled, we dropped by 1 milligram and it recurred. So now we do 0.5 to be safe. It just takes longer, unfortunately. And from my perspective, I don't think a lot of people understand how significantly different people on the spectrum are in terms of sensitivity. And that's my main message.
Thank you so much. I am going to throw to Julian and Mark for your comments around the issue of compounding. It's a real challenge in Australia. As you said, a lot of the medications aren't available in liquid form, so it makes getting those lower dosages difficult, but compounding is also expensive and can be quite tricky. Can you comment on that, please?
I'll just say a couple of things. So also in response to that story, I think one of the things that story illustrates is how much effect polypharmacy has starting and stopping drugs. Very hard to differentiate what's the underlying condition and what's harm from the drugs. And it sounds like harm from the drugs is a very prominent part of things. When I work in inpatient units, half of what I see at least is iatrogenesis. It's the effects of its adverse effects, its withdrawal effects from drugs. I talked about protracted injuries. A lot of people have been on and off drugs, in their psychiatric careers. So I think a lot of what we are perceiving as mental illnesses are the residual effects of what's happened before with drugs. And I think the second point is, to get off the drugs, you need to have a highly motivated general practitioner as your mother to get off. That's basically what you need, because most doctors don't know this area. They don't know how to get people off the drugs. They don't know what slow means. It's too much trouble. It's easier to keep on increasing doses, change drugs. So it never happens unless you have this extraordinary confluence of events. And one of the barriers is compounding medications. I think that makes it hard for people. I've given the lecture that you heard dozens of times. I get a lot of nodding from GPs and sometimes psychiatrists saying it makes sense, and we're not going to do that. No way, zero chance, because I've got 8 minutes, I've got 15 minutes, I can't see people for months and years. It means all the incentives are to keep prescribing. It's too expensive, it's too hard. I think from a health economics argument, I think, people are getting medications, they're being admitted, their functional capacities are dropping, they're not working, they're in hospital. I think the costs are immense from polypharmacy, from long-term unnecessary prescribing, from withdrawal effects, from protracted withdrawal. It's just never registered as withdrawal. If doctors, this to me is such a wicked problem. People come in, they're very unwell, it's written down relapse. And so the system recognises there's so much mental illness, we need more treatment. But actually it's withdrawal being misdiagnosed. So there's no recognition of the cost to the system. In that context of admissions, people not working, spending $50 a month on liquids or compounding is cheap as chips. But in the context of it not being registered, it's very expensive. So there's a very perverse accounting going on. Trying to, that's a very hard problem that I'm trying to work with economists on, but it's not very easy to get around. In that context, there are things you can do at home that are off-label options. There are things that, nurses can do and patients can do. It's, again, crushing up a tablet, putting in a glass of water. It sort of sounds highly transgressive to doctors. And, they sort of get a bit jumpy. They think it's going to affect my liability. But, anybody can do that. We've all done that with aspirin. It's, the tablets all dissolve in the stomach. That's how they work. All you're really doing is using a spoon to do what the stomach does. Shake it up. It's not actually as transgressive as it sounds. Yes, $50 a month, which is what compounding costs, might be prohibitive for an individual, but I think systems of care should think about it because it reduces strokes, falls, premature mortality, blah, blah, blah. Some of the drugs come as liquids. I mentioned escitalopram. So there are ways of navigating this issue. But as I said, it would be a lot easier if they came as standard tablets or capsules from the manufacturers. Would make life a lot easier for a lot of people.
Margaret, could I just acknowledge and thank you for sharing yours and Catherine's journey, because I think there's so many learning messages we can take home from that. I'd like to particularly pick up two things you said. One was Catherine's journey with catatonia, which I think among people living on the autism spectrum and people with intellectual disability is much higher occurrence than the general population. And so I think we do need a better approach to sophisticated assessment and management of catatonia, and an awareness that sometimes catatonia is life-threatening and needs really urgent treatment. And we need to do a better job. And it sounds like the advice that you had was really fundamentally flawed, and it's very distressing to hear. Now, the second is you highlighted the sensitivity of people on the autism spectrum. And I think we need to be thinking of that and thinking how it influences our approach to prescribing and deprescribing, because I think this is a population where often there are sensory sensitivities, a high kind of a heightened awareness of sort of interoception, and where we're likely to experience difficulty. And we need to really partner with the person to understand how they may respond and anticipate that difficulty and work with them to make sure that we can do a good job in prescribing or deprescribing, because it can be very, very difficult indeed. And I just wanted to acknowledge your leadership and your contribution to health in this space, which has been enormous over such a long time. It's been a privilege to work with you in the Australian Association of Developmental Disability Medicine, and there are Christelle and others here as part of the that association, which has really led national advocacy in intellectual and developmental disability healthcare, and your role as the secretary for such a long time has been incredible. So thank you. And I think that cost is significant. Would the PSA consider really strongly pushing, with certain caveats, where it is required for the safety of the person and for them to be able to access the treatment they need, whether it's prescribing or deprescribing? This is essential. Why isn't it treated as equally as other approaches and remunerated or subsidised? I think that's important.
Hi, Lauren. I'm Lauren. I'm a behaviour support practitioner, so I have a little bit of a different perspective on all of the medical talk. I'm very aware of our role in deprescribing and being very mindful that we are not medical practitioners, and the way that we enter the conversation is usually with a 30-day deadline and a medication purpose form, which adds more admin to GPs. And within that medication purpose form, it's very much tick box A for you're treating a mental health disorder, tick box B, I'm treating behaviour. It's absolutely not that simple, and everyone in the room always knows that. I guess less than a question, more, do you have any advice for non-medical practitioners, PBS practitioners, to open the door to have that conversation with medical practitioners that is not combative, that is not, I'm not a medical professional, I'm not questioning the prescribing decisions, and I don't want to question anybody's medical judgment, but it is my role to open that conversation. And do you have any tips and tricks on perhaps helping medical practitioners be more receptive to having that conversation?
Colleagues are fragile.
May I suggest something?
Yeah.
Would you consider suggesting a home medicine review referral? Yes. And then you link them together, and that the issue can be addressed. Yeah.
Other alternative practitioners to the medical community. Practitioners come see me in my clinic. I'm happy to hear about exactly what you think about it.
It says, I do not prescribe chemical restraints. And so
there's a massive value in non-medical professionals having an opinion. Social workers, behaviour practitioners, peer workers. It's my responsibility as an ARPA registered nurse practitioner to listen to the wisdom that's available. Doesn't mean I agree with you. I might disagree. That's fine, right?
But I disagree with you. People disagree with me, so that I can understand what is going on, rather than just.
Sure. So it's our responsibility. Maybe prescribers need to start taking bloody responsibility. That's what I was going to say.
But I'll just start with some fundamentals. We need to understand that the current generation of medical practitioners haven't been trained in this area. They haven't had exposure to people with intellectual disability. They don't know how to communicate. They have little understanding on the whole of the sort of support system and how we are to work together. And there is no current model that really supports doing it well and working together as a whole team around the person. That needs to change. We have another issue where our state regulators require us to polarise. It's this or that. And reform needs to occur. We should, I think, because of the harms associated with psychotropic prescribing, for whatever reason, have a system where we treat all psychotropic prescribing in a way that needs justification and should be subject to review. That's my personal preference. My psychiatrist colleagues will, I'm sure have me shot for that statement, but they're strongly opposed because many of them who are experts in the area believe they're able to make a clear distinction in majority of cases and shouldn't be interfered with, that their decision should not be questioned. But we need to carry people on a journey. We need to work collaboratively and try and, I think, educate and equip. And I think if you're getting the wrong response from a GP and they are antagonistic, maybe it's the wrong GP. Maybe it's time to choose someone who provides a level of expertise and way of working that actually is person-centred, because, it doesn't sound like that's the case.
Lots of things that drive that sort of behaviour. I mean, there's also legal incentives, kind of. People get sued for not prescribing. No one gets sued for prescribing. So there's lots of, risk aversion. People are pushing that direction. I don't know what changes that, but I think, risk aversion plays a big role with things. You're asking something constructive, how to have the conversation. I'm not sure bring in lived experience speakers or something to make, to animate the discussion, because it's obviously, if someone's sitting in their office ticking boxes, it's very different from hearing about stories of harm or negative outcomes. But I'm yet to crack that nut on how to convince my colleagues as well. So
one of the key pressures on GPs is time. Okay, we're saying we need you to get to the preventive healthcare needs for this group. And here you are putting a piece of paper in front of me and asking me to fill it in. It's a really difficult thing to do. So how about we set up regular reviews and more frequent consultations so we can identify the different domains where action needs to be taken and work together in a way that works for everyone, albeit the remuneration through MBS still isn't adequate. But, hopefully that will change. I think the practice incentives associated with My Medicare offer potential to remunerate practices as a whole for being able to address the health needs of more complex groups, including people with intellectual and developmental disability. That's one angle. But, we're a long way off from a proper remuneration of the sort of inputs that are required in the way that's expected from the point of view of the person and those supporting them.
Thank you very much. We've come to the end of our time already. That has absolutely flown. I think we ended on a fabulous question, because it is a question that we are honouring and recognising in our presence here today. We're coming together as professionals and colleagues and peers across a range of different sectors, a range of different disciplines, but we are here with open minds and hearts. We are here curious as to how we can learn and work together, and we are curious as to the opportunities to connect further. And I think that is actually the starting point. We are not passive recipients of information. We are able to use that information, to work with that information, to lift human lives, to be able to support people to live the best versions of our life. So I am so grateful for everybody's attendance here. I'm so grateful for Julian and Mark's contribution. Can you please give them a round of applause? Michelle has provided you with your feedback forms. Please fill in the feedback forms. It does help us to know what to look for when we're putting on these events in futures. If you want to make commentary about Raventresk statutory officers, the word is stunning. That's the word that we prefer. So please fill in your feedback form. All of our videos, our recordings, our presentations will be available on the webpage. We will send that out for everybody. Please put your lanyards into the boxes at the door. We are recycling because we're very sustainable in the Restrictive Practices Unit. Thank you so much for your time, everyone.